Thanks, Meyer. Again, it's great to be here at the 50th VEITHsymposium and try to convince this audience that TCAR is not better and it is more costly. Here are my disclosures, which you've heard earlier in the talk. So for any of us to say which is best, look, all of these revascularization strategies are excellent and they're complementary rather than competitive. And for every patient, they deserve an individualized risk-benefit assessment of what is best for them. Transfemoral stenting is one of those. Why do I say that? There is extensive data for major randomized data compared to endarterectomy ongoing versus optimal medical therapy, and more than 50,000, now well over 50,000, with independent neurologic adjudication trials to support that IDE and others, and extensive long-term experience and published data, which continues to improve. Starting in 2010 with the CREST trial, randomized trial, we know the results of that 4-year composite endpoint equivalent, and that was with dated data. More contemporary, 2016, the ACT-1 trial, randomized in asymptomatic patients between stenting and endarterectomy. Again, you can see both therapies were excellent at 5 years, durable and very efficient. And then even more recent, EAST-2, 3,600 plus patients in Europe. Again, equivalency between carotid stenting and carotid endarterectomy with less cranial nerve palsies as seen earlier. Furthermore, both therapies there are very durable. At 10 years published data in New England Journal, again, both very good at preventing ipsilateral strokes and maintaining vessel patency equivalent at 10 years. The results continue to get better. In the last wave of trials, most of them are less than 3%, often 2% or less for stroke, death, and MI at 30 days. And proximal protection is even better than the data I showed you previously, with less than 2% stroke rate and a large number of patients going across all patient subgroups, including symptomatic and octogenarian. The contemporary CREST-2 registry, for all patients, 2% stroke death rate at 30 days, even better for asymptomatic. And then the newer technologies, which you've heard of already, with the small cell micromesh stent or the added 40 micron second filter with a Contigo device, were just presented a couple weeks ago with extremely low stroke, death, and MI rate at 30 days. And for the Contigo system, 1 year data, no major strokes and very good results at 1 year. So is TCAR great? Is a good therapy? Absolutely. We've already heard that. It's an elegant flow reversal. But does that mean we should do away with transfemoral stenting? I would absolutely say no, because we don't have any comparative randomized or long-term TCAR data, and as we've heard from Bruce, some of the data is subject to bias, and as we'll talk about, the cost is significantly higher. Let's look at their data. The Roadster 1 pivotal trial, 141 patients, 30-day primary endpoint. If you look at intention to treat, which is what we should look at, the stroke and death, 2.8, stroke, death, and MI, 3.5. Good, but no better than what I just showed you for transfemoral carotid stenting. What about Roadster 2? Again, a 30-day primary endpoint. And as Bruce already mentioned, there's problems with a per protocol analysis when you somehow sponsor exclude 60 patients. Why is that important? This was one of the patients excluded. They died. They had a good TCAR result, but they had this cerebral bleed. They were excluded. Why? They didn't get Plavix within 24 hours after the procedure. I think everybody can understand the inherent difficulties with a per protocol analysis. So if you look at intention to treat for Roadster 2, 1.9 stroke, 3.2 stroke, death, and MI, good, but no better than what I just showed you with transfemoral carotid stenting data. It's hype only if we try to oversell it. As we've already heard, there's no randomized data comparing TCAR to any other revascularization or treatment strategy, nor is there long-term follow-up. And again, some of the data types are inherent, as we've already heard from Bruce, either sponsor study or Mark's work was eloquent, but it's still self-reported data studied retrospectively that has some inherent issues. And again, some of the 30-day endpoints may capture, not capture, the events that happen with carotid dissections, as we've already heard earlier in the session. Finally, the cost is significantly higher for each part of it. This is from Washington University, showing double the cost of TCAR compared to carotid endarterectomy. In University of Pittsburgh, you've heard the cost margin is much better for transfemoral stenting. The cost is double for TCAR for transfemoral stenting. So in conclusion, transfemoral stenting has extensive, rigorous, supportive data with equivalency to endarterectomy and long-term data. TCAR is an excellent strategy, but lacks this similar data. It is more costly, and I think all of us deserve an individualized approach to what you offer your patients. Thank you very much.